Yeah, so my name's Marian, and I'm a speech pathologist at Calvary Healthcare Bethlehem. And I'm going to be talking to you a little bit about some research I'm currently conducting looking at secretion management, called Taking the Secret Out of Secretions, Developing Evidence for the Management of Oropharyngeal Secretions in Motor Neurons Disease. It was a colleague that came up with the cheesy title, but it's stuck. Okay. So I'm hoping by the end of this we'll all have a little bit more knowledge about the kind of secretion management issues people can experience in motor neurons disease and some of the typical interventions we use. And also a bit of knowledge about the current research there is out there about those interventions, or rather the lack of research really. And then I'm just going to give you a little overview of the small project I'm currently running at Bethlehem Hospital. So I guess just to start off, but when I'm saying the word secretions, what I'm actually talking about are oropharyngeal secretions. So that is basically the saliva in our mouths and in our throats, okay? And our three major salivary glands are producing two types of saliva, thin saliva and thick saliva. So your submandibular gland and your parotid glands are producing mostly thin saliva, and your sublingual gland is producing mostly thick. And they're producing a lot. So the typical adult is producing anywhere between 0.5 liter to 2 liters of saliva every day. And all that saliva is doing a lot of different things. It's helping me speak, it's helping us chew our food, and it's cleaning our teeth and our gums. But to do all those things, we actually need the muscles of our mouths and of our throat, our bulbar muscles, to be working well and working well together, okay? To actually maneuver the saliva around the mouth and then physically clear it through the throat when we're finished. So in motor neurons disease, at the center of secretion issues is really that change in bulbar function that results in difficulty swallowing and therefore difficulty clearing the secretions from the mouth and the throat. So what we can see is a buildup of saliva in the mouth or the throat secondary to this. But of course, as Jody touched on, it's complicated, it's multifaceted, and that's what this graph is trying to demonstrate. And again, all the things Jody touched on, it can be secondary to dehydration, some of the medications our patients are using, antidepressants, antispasmodics. NIV use is often described as quite drying as well. So it's multifaceted. And it's usually a combination of these factors that lead people to have difficulties, either managing thin secretions, thick secretions, or both. And quite often it's described as one of the most distressing symptoms that our patients are experiencing, because it can lead to drooling, coughing, choking, difficulty swallowing, difficulties communicating. And it's estimated that 50% of patients with motor neurons disease are having problems managing their saliva or their secretions. So what are we doing about it? So there's lots of different interventions, again, as Jody touched on. But what we first need to do is actually do a thorough assessment to clarify what the problem is. So is it thin secretions, thick secretions? Where are they happening? When are they happening? And actually, how distressing are they to the patient? And then it's based on this thorough assessment that we choose our interventions. And again, MDT approach is vital. So we work with our physiotherapists, our dietitians, our OTs to achieve that multidisciplinary input, okay? So, and again, there's lots of options. Positioning is vital, as the OTs and physios talked about this morning. Speech pathologists look at behavioral strategies to try to clear the secretions naturally by achieving a swallow. We can talk to our doctors about prescribing anticholinergics to actually dry out those thin secretions. And again, we work with our physiotherapists who sometimes look at assisted cough to try to clear those secretions. And I guess it's a purposely busy slide to just highlight there's lots of different interventions. And for thick secretions, again, lots of options. I guess touching on the nebulizer that someone questioned, in our clinic, anecdotally, it's something that we actually have a lot of success with and we prescribe often. And we use that for thick pharyngeal secretions. And what we do is we do that in the theory that it's actually breaking down the thick secretions. But what we try to promote then is some swallow action after that to physically clear it. Sometimes we use mucolytics, and also again, and I guess we use a lot as well as fruit juices. And the reason we use that is because they've actually got proteolytic enzymes in them that actually break down the thick phlegm. Okay, so, and I guess just what I'm trying to say there is there's a lot of different interventions, but actually, as it turns out, there's very little evidence for anything that we're really using. So a Cochrane review was conducted in 2011, and that only found evidence for Botox. So that was Botox to the submandibular and parotid glands for thin saliva. And at 2 and 4 weeks, that was found to be effective. And that was just a subjective report from the actual participant. In 2016, when NICE were writing their guidelines, they found no evidence for anything that we're doing for the management of thick secretions. And again, they found the same study for Botox, and they just found low to poor quality evidence for the use of anticholinergics. So given that, like a lot of the research that is out there really takes the form of surveys. So this one carried out in the UK in 2017 just gathered evidence about what we're using. And again, it just found really that a lot of centres are using the same interventions, but it didn't really comment too much on efficacy. So really, at the moment, there is a significant lack of research into the interventions that we're using. And as a result, what we're doing is really based on clinicians' experience and based on trial and error. So this is where my sort of project comes in. So it's a really simple project, and all I'm trying to do is identify what we're using at Bethlehem to manage either thin or thick secretions. And then I'm using a really simple measure to review the efficacy of those treatments. So what we're doing is in speech pathology assessments for anybody who we are recommending a new intervention, we're recording that intervention. We're getting the participants to do a quality of life measure at both the start and the end of the research study. The speech pathologist is recording what type of secretion issues the individual is having, where they're happening, and what they've actually prescribed. What we're doing then is at 1 week, 3 week, and 8 week intervals, we're contacting the participant to ask them those questions. So where were your secretion issues? What type were they? What did the speech pathologist prescribe? And was it effective? And then at the end of that, we're at 12 weeks then, where we're repeating the quality of life measure. So my primary outcome measure is just a subjective report from the participant of whether or not the treatment has worked. And I'm really using that really simple measure because the only study, the Botox trial, that was the measure they used, dichotomized improvement or not. And the secondary outcome measure I'm using is that quality of life scale. So the story so far for my research project is I've got 17 participants, and 5 of those participants have completed up to the 8 week point. So if you have a look here, so someone's asking that question about saline nebulizers. So for thick oropharyngeal secretions, the speech pathologist recommended saline nebs with pineapple juice. At 1 week, 3 week, and 8 weeks, the participants said it did improve secretion management. But then actually, if we look at, for example, this one here, we're in collaboration with with a neurologist. The patient was started on amitriptyline for thin oropharyngeal secretions. When we made the call, they were telling us that they were prescribed dark grape juice and they had no improvement. So it's interesting to, I guess, finding out a bit more about the patient's own knowledge of their issues and why we're prescribing what we're prescribing. So what of the challenging has been? Well, it's been really difficult actually conducting research alongside clinical workload, and sort of especially when you're trying to follow up patients at sort of regular intervals. So that's been challenging. And also learning more about the ethics procedure, that was very difficult, but I'm really fortunate that at Bethlehem, we're a research centre, so I had access to research nurses that helped me with that process. Yeah, so basically in summary, oropharyngeal secretions are often described as the most distressing symptoms for patients with motor neurons disease, but there's currently limited research and no evidence-based guidelines on how to manage them. And in absence of these guidelines, all I'm trying to do is gather really simple evidence about what we're doing at Bethlehem and whether or not it actually works. So those are my references and my contact details.
Thank you very much, Marian, for your presentation. Does anybody have any questions? Yes, we've got 2 hands up in the middle here.
Thanks, Marian. You've obviously said there's not a lot of evidence, so I'm just interested in your subjective opinion on the use of suction machines for secretions.
Now, suction, every time I've done this presentation this year, someone's asked that question. And I guess at Bethlehem and as a speech pathology department, what we say is usually that it's contraindicated. So what we're saying is it sort of stimulates more, and then you're using the suction, and it can become quite like a bad cycle. But in saying that, though, there are some of our patients that do end up using it. And so what we say is it sometimes is a last resort. So if we've tried all those other interventions, that's the way forward. I sometimes wonder, though, when patients are asking about that, like what they think they're asking for. Like I sometimes think it's that idea that it's going to be a magical solution where you're going to be able to suction out those thick pharyngeal secretions. So yeah, it's a difficult one. We're requested a lot, but we usually manage it using other ways.
Okay, I think that was...
And just a quick follow-up from that. With that, so if nurses are using that in an acute setting when, say, someone might come in unexpectedly, do they need to have or be taught that technique of how to suction, or can anybody do it?
And again, I guess it's a nurse that would need to answer that question for it within our team, because it's not something that we use often. Actually, as speech pathologists, we're not, our training in that isn't up to date. And again, it's just that idea, like if our patients are going into acute settings, someone touched on that earlier, it's that idea of making sure the handover is good. Because really, at Bethlehem and in general, we're managing those secretions in other ways. So I wonder what we'd be doing is just handing over really what we're usually doing to manage those thin secretions rather than using that suction. Because what happens is, I guess, it's different if someone's going on with an acute chest infection or something that's exacerbating those issues. But what happens is people come out of hospital, and that's when they start asking us for the suction machines as well, those magic machines. So, yeah.
Any other questions? No? Okay, thank you very much. Thanks.